Order. I call this meeting on the Standing Committee on Health to order. My name is Suzanne Lonis-Croft. I am the MLA for Lunenburg, and I'm the chair of your meeting. Today, we will hear from the Department of Health and Wellness and the Nova Scotia Health Authority regarding collaborative practice teams and doctor recruitment. I'd like to remind everyone to turn off their phones and put them on vibrate. And please exit, should we have an emergency, through the exit doors and go out to your nearest exit, which would be Granville Street. We then go up to the Grand Parade and meet there. Also, I will welcome Dr. Mary here today as the Acting Deputy Minister of Health. This is your first time to the committee, so welcome. And I will ask that we do introductions of our members, starting with Ms. DiCostanzo.
Good afternoon, everyone, and welcome. My name is Rafa DiCostanzo. I'm the MLA for Clayton Park West.
Welcome to all our guests. My name is Keith Irving, the MLA for Kings South.
Good afternoon and welcome. Hugh McKay, MLA for Chester St. Margaret's, and I'm subbing for Ben Jessam, MLA for Emmons Plains, Lucasville.
Good afternoon. Pleased to have you all here today. I'm Bill Horn. I'm the MLA for Waverley Fall River Beaverbank, and I'm subbing for Gordon Wilson from Digby Clare, MLA.
Good afternoon, everyone, and welcome. My name is Tim Hallman, MLA for Dartmouth East, and I'm substituting for Carla McFarlane, MLA for Pictou West.
And I'm Barbara Adams. I'm the MLA for Cole Harbour Eastern Passage.
Hi there, I'm Susan LeBlanc. I'm the MLA for Dartmouth North.
Hi, good afternoon. Tammy Martin, MLA Cape Breton Centre.
And our clerk today is Judy Kavanaugh, and our assistant clerk is Sherry Mitchell, and our legal counsel is Mr. Gordon Hepp. I will now ask that our witnesses introduce themselves, beginning with Mr. Grant.
I'm Don Grant, Senior Executive Director of Physician Services at the Department of Health and Wellness.
I'm Jonathan Veal, Chief Design Officer and Acting Executive for Primary Health Care.
Nicole Bouthier, VP Medicine.
Dr. Mary, can you just introduce yourself for Hansard's purposes?
My apologies, thank you. Tom Mary, Acting Deputy Minister of Health and Wellness.
Nicole Bouthier, Vice President of Medicine for the Nova Scotia Health Authority.
Hi, Grayson Fulmer. I'm the Senior Director of Medical Affairs for the Nova Scotia Health Authority.
Good afternoon, Lynn Edwards. I'm the Senior Director of Primary Health Care and Chronic Disease for the Nova Scotia Health Authority.
Maria Alexiadis. I'm the Head of Department of Family Practice in Central Zone.
Hello, Denise McDonald-Billard, Project Executive with the Department of Health and Wellness, Primary Health Care.
Okay. I would just like to let our guests know that I will acknowledge you before you speak so that Hansard has a time to turn on your microphone. And just with the fans on, you may have to speak up a little louder. Make sure your microphone is directly in front of you so that Hansard can record and everyone here is able to hear. I would like to invite our guests to do opening statements, starting with Dr. Mary.
Thank you very much, Madam Chair, and good afternoon. This is my first appearance before the committee. Before we get to questions, I will make some brief opening remarks. Nova Scotians are receiving very good health care by our healthcare system. There are dedicated, skilled health professionals providing care across this province. Because we have doctors and staff with special skills, we provide specialized care to children and adults for the people of Atlantic Canada. Two such examples of this kind of care are heart and liver transplantations. I have been fortunate to see our healthcare system from several perspectives. As a practicing physician, as dean of our medical school, and in the past 3 months as acting Deputy Minister of Health and Wellness. Over the past 3 months, I've traveled throughout most of the province. I have left Cape Breton till last because I want to go there in October when the leaves are out. But I have actually been to Cape Breton for a flying visit. This one would be a more comprehensive visit. On these visits, I've talked to physicians and other healthcare professionals and seen firsthand the state of our healthcare facilities. And I was very fortunate to have Miss Janet Knox accompany me on many of these tours, so I had access to the entire hospital and healthcare system, so very good visits. Our health care system is not perfect. We know the challenges, but the department and the health authorities are working very hard to deal with these challenges. Our emphasis today is going to be on how we're working to solve these problems. Primary health care is the backbone of any health system, including ours. Access to primary care is a priority. What is primary care? A simple definition is the day-to-day care given by a healthcare provider. In Nova Scotia, as a simplification, there are three main avenues for primary care. Collaborative family practice teams, also known as collaborative care centers, which we'll talk about in some detail today. Family medicine practices, which could be either a group of physicians or solo practitioners, and last, walk-in clinics. Collaborative family practice teams are a key component of our primary care strategy. These teams provide a mix of healthcare professionals that include physicians, nurse practitioners, family practice nurses, social workers, pharmacists, dietitians, occupational therapists, and others. When we analyzed physician MSI billing data, we found that patients of these teams had fewer emergency department visits and lower hospitalization rates than patients of physicians who are not part of a collaborative family practice team. We also found that patient satisfaction is high, and the healthcare providers in these teams are also satisfied. Due to the hard work of many physicians and staff under the direction of Ms. Lynn Edwards, who is here today, the number of teams has grown in a short time to 84, and these are distributed throughout the province. By the end of this fiscal year, government will have invested an additional cumulative total of $58.4 million in primary care since 2016. There are many other ways. This is not the only way to try and ensure that we can improve primary care. An obvious example is the $1 billion+ being invested in the QE2 New Generation and the Cape Breton Regional Municipality redevelopment projects. So in addition to providing state-of-the-art facilities, one of the ways that such investments help the healthcare system in any region is when you grow the region economically, there's more jobs, and you really influence the social determinants of health. So one of the things we're going to do is to measure the impact that these projects have on that aspect of healthcare. Now, I'm either fortunate or unfortunate enough to have been a physician for 49 years, so a lot has changed over that period of time. People in all occupations work differently, and in healthcare, especially among physicians, it's no different. There's more emphasis on work-life balance, which typically reduces the number of hours worked. The demographics of our population has changed over that period of time. We are living longer, which is a success story, and indeed, life expectancy in Nova Scotia, on average, is 81 years for a male and 83 years for a female. We do have the oldest population in the country, or the oldest percentage of those 65 and over. That's a good news story. But it does mean that we need more health care in our golden years because we wear out. I will now turn briefly to recruiting physicians. So recruiting, like most things in healthcare, does not have one simple solution. To attract doctors to Nova Scotia, we must have a suite of constant coordinated efforts that include both long-term and short-term strategies. Just a few weeks ago, you heard from Dr. David Anderson, Dean of Dalhousie Medical School, about increasing the number of medical seats and the number of places for residents. In fact, 25 places not so long ago. This is a long-term strategy. My colleague, Dr. Boutelier, will discuss recruitment in more detail shortly. You've often heard, I'm sure, that if we only paid doctors more, our recruiting problems would be over. So consider that Alberta has the highest paid physicians in the country. If you look at the number of family doctors per 100,000 population in Alberta, it's 121. In Nova Scotia, it's 123 per 100,000. So compensation is certainly a part of any recruitment strategy, but it's not the only part. We're currently in negotiations with Doctors Nova Scotia, and we want to arrive at a place we're very competitive, but I can't say any more about that because we are at the table. The Department of Health and Wellness and NSHA are two members of the recruiting team, but there are many other members, including physicians themselves and communities. And the communities are most important. So communities have started to take a lead in trying to help with the recruiting process. And before I took on this responsibility, I was part of Lunenburg Now, which has been working very well, and in fact was one of the leaders in physician recruiting. But that now extends right across the province, from Glace Bay to the Valley to Digby and so on. And communities have come up with innovative ways to entice physicians to their area and to make sure they're welcome when they come. Town of Kentville recently had a big party for physicians who have been there for a while, and that certainly had a positive impact, not only in Kentville, but right across the province. In Glace Bay, my favorite, they went jigging for mackerel, although I didn't know you used to jig for mackerel. I thought you caught them on a hook. But so when I go to Glace Bay, I'll try that out. Government has a number of financial incentives to help attract or retain doctors. Two such examples are tuition relief and debt relief, but there are many more, and my colleague, Dr. Grant, can elaborate on that if you wish. But doctors are also key to recruiting doctors, and I'm pleased to say that Doctors Nova Scotia does participate in that as well. My final comment is this. Getting to the healthcare system that we all want will only happen if all Nova Scotians work together as we are doing here today. Over the next hour or so, I look forward to telling you what DHW is doing and to hearing your ideas on how you can help. Thank you, and I will now turn over my time to my colleague, Dr. Boutelier.
Sorry, Dr. Boutelier.
Thank you, Dr. Mary. Good afternoon. My colleagues and I are pleased to be here to meet with the committee. As a physician, I know how important it is to have access to the right care in the right place at the right time. As Dr. Mary has mentioned, teams and physicians continue to provide quality care across the province, but access continues to be a challenge for some Nova Scotians. Our population is growing, and the demands on our healthcare system are changing as people in our province are aging and medical problems are becoming increasingly complex. Additionally, more people are leaving the health workforce through retirement than are entering. These challenges didn't evolve overnight, and solutions require strategic and measured efforts from all of the stakeholders. Adapting to these changes across the system takes time to produce results. Primary health care, as we have heard, is the foundation of the health system. For the last few years, we've been working to create more collaborative practice family teams and strengthen the existing teams that are across the province. Today, there are more than 80 collaborative family practice teams. To support these teams, we have hired more than 130 allied health professionals, one of the largest investments in frontline care in the history of the province. Collaborative teams offer comprehensive, coordinated, and accessible care for their patients. Many newer doctors, nurse practitioners, and other primary healthcare providers have been trained in a team-based approach to care, and they look for these opportunities to work as part of a team. Evidence and experience agree that this model improves health outcomes and helps us recruit new providers. Working with communities and our partners, we have recruited 130 doctors in the last fiscal year. That's a 26% increase from the year before. 58 of these were family doctors. Since 2016, we have recruited 385 doctors to the province. The College of Physicians and Surgeons of Nova Scotia have reported a stable number of active licenses since 2015. While we have seen some success in our recruitment efforts, we will continue to focus our efforts and evolve our strategies to overcome the identified challenges. Demand for health professionals is increasing globally. We are competing nationally and internationally to recruit. It is important to note that the need is not just limited to doctors. Nursing and other staff vacancies are challenging to fill, especially in rural areas. Today, we are working to fill more than 80 family medicine positions and 90 specialist positions. There is more to the story than just these numbers. Unfortunately, it's not as simple as just hiring more doctors. If we were simply able to drop a doctor into every open vacancy, it would not guarantee access to care in the right place for all Nova Scotians. This underlines the importance of community-level strategies. Physician recruitment was transferred to the Nova Scotia Health Authority in July of 2016. In 2017, we provided our first recruitment strategy, which set the benchmark. Since then, we have engaged external expertise and built partnerships to extend our presence in Canada and in other jurisdictions where we had a competitive advantage. We now have a sophisticated brand and a website, tools in place to represent ourselves when we're out on the road, and improved processes and partnerships. In this short time, we've increased our recruitment team from 3 employees to 11. This includes 2 recruiters in each zone, 2 administrative staff, and a director who ensures strategic focus and evaluation as a priority. Our recruitment and marketing plans are grounded in engagement with physicians and partners. We market our opportunities with information provided to us from physicians about what they find rewarding about practice in Nova Scotia. Relocating for any career is a huge decision. We are simply not pitching positions or hospitals to doctors. We are working to match them with a community. This is a decision that impacts their whole family. We have increased our focus on international recruitment. Doctors from abroad now count for 20% of the new doctors who have started practice in the last year. We've increased our focus on the licensing and immigration with our partners at the College of Physicians and Surgeons of Nova Scotia and the Nova Scotia Office of Immigration. Since 2018, 31 of the doctors entering the province's immigration stream were from the UK or Ireland. We have also increased our campus visits with residents at medical schools across Canada and doubled our attendance at national and international career fairs. We have created a position to focus specifically on medical students training here in the province, which came about through our work with our partners. Recruitment is the work of many partners. Our plans are enhanced by the interest in this work that many groups bring and that they have value to bring. We must work together as a province, and we are. Physicians have always been front and center in the work to recruit other physicians. We know that peer connection is crucial. We have been working to better embed doctors in our processes, and they are key members of our team. Physicians are traveling with recruiters across the country and internationally to events and job fairs. They offer testimonials that we use to promote our province. They host events to welcome new medical staff, and physician leaders have been an integral part of the formation of community recruitment groups. We have a provincial recruitment and retention advisory committee that is made up of many partners: the Department of Health and Wellness, the College of Physicians and Surgeons, Maritime Resident Doctors, the College of Family Physicians, Nova Scotia Office of Immigration, Dalhousie University, Doctors Nova Scotia, the Nova Scotia Federation of Municipalities, as well as representation from community groups and health foundations. This committee works together on opportunities to use their shared knowledge and resources to improve recruitment efforts. Our recruitment team also works closely with community leaders to tour interested doctors around the province. These groups have done great work in welcoming physicians and their families for site visits and into their community. Hosting a welcome event for new physicians is as important as sharing details on practice opportunities and call schedules. These actions are large and small and are meaningful. They make an impact. Our progress with recruitment and establishing more collaborative practice teams has been making a difference for Nova Scotians. More than 110,000 people have found a family doctor or nurse practitioner since we began tracking this information 3 years ago. On average, about 6,300 people have found a family practice each month over the last year. There is still much more to do, and we continue to recruit every day. As we move forward together, we look forward to sharing updates on our progress. Thank you.
Thank you for your opening remarks, and we will take questions now, beginning with the Liberal Caucus for 20 minutes. No? PCs? Oh, sorry, the PC Caucus for 20 minutes. Mr. Halliman? Oh, okay, Ms. Adams.
Thank you very much. I'm very happy to have all of you here today because there's no other topic that is more important to our constituents than their health and the health of their families. And so what we get answered today is going to help everybody understand a little bit more what's going on. I have some questions that I prepared, but I want to comment and ask a question about some of the things that were said by our initial presenters. The IHI Triple Aim is a framework developed by the Institute for Healthcare Improvement that describes an approach to optimal health system performance, and that it has to be developed to simultaneously improve three things. Improving the patient experience, which includes patient satisfaction, and you alluded to the fact that that was high in collaborative health practice. Reduce capita cost of health care and improve the population health. So we know if a patient is given more time to talk to somebody, they generally report higher satisfaction. That doesn't necessarily mean that they have improved health or that the collaborative health team approach has actually reduced cost per capita per person in the province. So I'm wondering if you can say of those three aims, where one of them has been achieved in terms of patient satisfaction being high, do you have concrete evidence that this approach has improved the population health or reduced the capita cost per resident in Nova Scotia?
And who are you directing that to?
I guess the Deputy Minister.
Dr. Mary?
Thank you for your question. And I did reference one aspect of improvement in population health, which is the fact that patients in collaborative care teams don't go to emergency as often as those who are patients in other settings, and they have fewer hospitalizations. So that's indirect evidence for better health care. We have actually started a prospective study to better measure that won't be available for another little while. There are also many parameters that are monitored through the Health Authority Quality of Care Program and that are sent on to the Department of Health and Wellness. I will just mention a couple, and then I will ask Dr. Boutelier to elaborate on a few more. So that's a key priority, to monitor quality in the healthcare system. A couple that readily come to mind for me where NSHA, and I'm talking about it in particular, but we do the same for the IWK as well, performs better than the national average. And one of those is readmissions to hospital after you've been discharged. So it's not uncommon if you're sick and you go home that whatever you were sick with sometimes gets worse, even though you think you're better when you go home, and you have to be readmitted to hospital. So that's monitored by hospitals across the country. And the way that we benchmark ourselves is by looking at data from hospitals that are of similar size across the country. This methodology is standardized by the Canadian Institutes for Health Information. So that's one of the ways we look at it. I could go on with more, but if I may. Sorry?
Ms. Adams?
We are limited in the amount of time that each of us gets to ask questions. So just want to point that out.
Dr. Mary?
So I think I've gone over my time in that question.
No, you didn't. No, you didn't.
Oh, you? Okay. But I think that's a question that's important for the people of Nova Scotia to know. So if I may, I'd like to ask Dr. Boutelier to just point out quickly a couple of more of the key measures that we look at and where we actually do better than the
Dr. Boutlier?
Thank you. And I think that I'm going to ask Lynn Edwards to talk about the quality with specific to primary healthcare collaborative teams, as that's what you were referencing with those 3 questions.
Ms. Edwards.
Thank you very much for your question. The triple aim is a well-known methodology that the IHI has developed. We have seen some provinces in Canada that has added a 4th aim, which includes provider satisfaction. So with respect to what we ask of our teams and how we build a quality environment with our collaborative family practice teams, we ask all of our teams to develop a team agreement and identify how they're going to provide care, the best care they can, to the patients that they currently have in their care. As part of that, they're to look at what kind of hours of service they offer, etc. We are working with our teams to understand quality and what quality improvement is, and we just had a large forum just a few months back where each of the teams came in and identified how they want to make improvements, where they feel they need to make improvements, and they've gone back with those plans. We report on how we've been able to develop the teams, the numbers of staff that we have hired over the last number of years. We also report on the numbers on the Native Family Practice Registry as some examples of the pieces that we report to the department on a regular basis. Thank you.
Ms. Adams.
Thank you. I'm not sure that answers the question as to whether our population is actually any healthier or that we are actually spending less money per capita. The current state assessment of the primary healthcare system in Nova Scotia was released a new document in August 2019, the Primary Healthcare System Baseline Report. And in it, it outlines a lot of the indicators that were selected, and they narrowed them down from several hundred to 28. When you look at the stakeholders who were invited to participate in preparing those indicators, there were 5 physicians out of all of the stakeholders, and only 1 was really practicing full-time in family practice. One of the things that we get asked all the time is whether physicians have been included in the stakeholder engagement process. And when I read this report, there was very little physician involvement in that. So I want to go back to the very beginning and ask a very basic question. Since, I think you said July of 2016, the Nova Scotia Health Authority took over physician recruitment. I think a lot of people would argue that that did not improve physician recruitment, and you can correct me if the numbers suggest differently. But what I want to know is, given the fact that the Nova Scotia Health Authority and the Department of Health and Wellness have to work together, when I look at the list of where all of you work and where everybody else works, it's very difficult to know who's where, who's on first and what's on second. Is there a hierarchy chart that outlines everybody in the Department of Health and Wellness and where the vacancies might be, and everybody in the Nova Scotia Health Authority in administration that we can get our hands on that says, this is what everybody does and this is who they report to? Does that hierarchy chart exist anywhere?
As in an organizational chart?
As an organizational chart for the Department of Health and Wellness, an organizational chart for the Nova Scotia Health Authority, and how they interact as to who reports to who. Does that exist, Dr. Mary?
Dr. Mary?
So I will answer for the Department of Health and Wellness. Yes. Dr. Boutlier.
Dr. Boutlier?
Yes, we have organizational charts.
Okay. Excellent. I would like to request that those be submitted to us because I've never been able to see one and to know who responds to who. So I'm going to ask a very specific question. If you have a long-term care facility and there are 2 physicians who work there and they both decide to leave, who do they contact first to say, we're leaving? And then what is the response supposed to be? Dr. Mary, or
Dr. Boutlier?
Dr. Boutlier?
So every zone has a structure of a zone medical executive director, and then there are zone heads per different services. So there's a zone head for emergency, there's a zone head for family medicine, and so on and so on. everyone under that structure would have site responsibilities as well, or a network lead, in particular for primary health care or family medicine. So in the terms of long-term care, physicians typically in our province are family physicians that are delivering that care, and they would report to a network lead, and that would be their first point of contact. The network lead would report to the zone head reports to the zone medical executive director.
Ms. Adams?
Thank you very much for that. Can you tell me how long a physician who says we're leaving should take to get a response from the Department of Health and Wellness?
Dr. Boutlier?
That was directed towards the Department of Health.
Oh, Department of Health? Sorry, Dr. Mary.
So typically, the clinical response would go to, or the physician would notify two parties. Clearly, as Dr. Boutlier outlined, that administrative structure. But Mr. Grant works with physician services, in fact, runs that branch for us. And I would like him to respond to that question, if I may.
Mr. Grant?
So in terms of how long a physician should wait to get a response, the response time should be fairly immediate in terms of a response time. It will vary depending on what is going on at the branch at the time, but we do endeavor to try and get back to people as quickly as we can.
Ms. Adams?
Thank you. Can you clarify that for me? Are we talking a couple of days or a couple of weeks?
Mr. Grant?
I can't give you an exact timeline. It would be anywhere from days to weeks, yes.
Ms. Adams?
So on June 18th, two physicians at Ocean View Continuing Care Center in my community of Eastern Passage indicated and sent a letter to the participant you mentioned earlier and said, we're both leaving. And the target date was September the 18th, which is next week. It took 6 weeks before they got any response. And then that response was to send an email out to some physicians to see if anybody was interested. To my knowledge, the first group meeting was held August the 27th or 28th. So can anybody explain to me why in this particular situation, two physicians said they were leaving and nothing happened? And I have a cousin living in that facility whose wife is about to find out, if she watches TV today, that those doctors are leaving. So how did this happen that 6 weeks went by before an acknowledgement and then nothing for another several weeks? I don't understand how that happened. And if this is an example of what happens, the hierarchy may be outlined on a piece of paper, but I don't know how it worked in this situation. And I'm wondering who is responsible for the breakdown in communication here? I don't know who wants to answer that.
Hi, Dr. Alexandrius is able to answer that.
Dr. Alexandrius?
Dr. Alexiadis, thank you. And I thank you for asking for the org chart, because that's an important thing for you to have to understand. But the org chart also creates networks. And in fact, that information was brought to me weeks before, as the doctors were in communication as being a family medicine or family practice head. So the actual issue, the particular issue, was being worked on prior to all these meetings that were being had, and recruiters are being notified. We were looking to see who we could have. So it wasn't as just overnight. At the same time, you realize the challenges of trying to find people to take over those positions. As you may be aware, that right now, the current medical community out there is working very hard. The new doctors that are coming out are also looking at how they're going to set up their practices. And in that includes comprehensive medical care, as well as long-term care, as well as perhaps ED, as well as perhaps inpatient, but they choose how they make that practice up. So we put advertisements through our More Than Medicine recruiting place for those physicians. We internally looked at finding other physicians to do it, and we almost have a solution. At the same time, I think it's appreciative that it's on the looking at it, it seems like maybe nothing has happened, but much has gone into that issue.
Ms. Adams.
So from the time that the physicians wrote that letter, how long did it take you guys to contact those physicians to let them know that you had received their notification? Dr. Alexiadis.
Dr. Alexiadis.
That letter came afterwards. We actually knew before the letter that was sent.
Ms. Adams.
Okay, so that's different than the information I've been given. So we're going to move on. I appreciate how hard it is to recruit physicians, but I also think that the people who are living in that facility had a right to know what was happening and still have the right to know what's going on, because when they stopped admitting patients to a long-term care facility, that's important information for families to know, especially if there isn't going to be coverage during the day and they're going to have to be shuffling off to emerge as their backup plan for care. One of the questions that I wanted to ask is, we went from 2015 to 16, 39 collaborative health centers to 83 in 2018 and 19. So achieved the goal of creating those collaborative health teams. And yet the number of Nova Scotians without a primary health care provider for the past year hasn't changed one iota. So I'm just wondering if one of the goals of creating these collaborative health teams was to improve access to health care, how come it didn't happen?
Dr. Mary?
So, Madam Chair, I would like to have two people answer that question. Sitting on my immediate left is Mr. Veal, who runs the patient registry for, so I should say citizens, because they're not patients at this point, who don't have a family doctor. He can tell you what's been done there and what progress has been done. And then I think Ms. Edwards could answer the second part of the question.
Okay, Mr. Veal?
So with respect to your question about improving access and what's sort of happening there since 2015, so what I can tell you is that as of September 1st, 2019, there's about 52,000 Nova Scotians on the Need a Family Practice Registry. This represents 5.7% of the population. And as you noted, the registry has stabilized since 2019. So I just want to point out that when we create the registry, it takes a little while to start building up a list of Nova Scotians as people are added to that registry. The largest percentage of unattached patients it varies significantly across the province. So Western Zone is certainly one of the areas where there's a large need, and there's a large number of Nova Scotians on the registry. Northern, followed by Northern, then Central, and then Eastern Zone has remained relatively constant as we've had this registry. So with respect to your point about access, the number of Nova Scotians has been decreasing in Central Zone, while it has been slightly increasing in Western and Northern, and remained relatively stable or the same in Eastern Zone since 2019. Since November 2016, which is around the time when the registry was created, and Ms. Edwards can clarify more on this, over 110,000 Nova Scotians have found a provider. 57% of them have found it using the registry. So there is while the bottom line number has remained constant recently, the throughput on the registry has been the 110,000 number. A big factor contributing to this has both been the collaborative family practice teams, as well as the unattached patient bonus, where there have been 41,000 total claims, and 16,000, 40% of the patients associated with these claims were already on the registry. So Ms. Edwards can clarify about the access issue on the registry if she
Ms. Edwards, you have about a minute.
Thank you very much. So what I'd like to add to that is that our collaborative family practice teams, it takes a while to start practice, to build a collaboration, and to take patients on from the Need a Family Practice list or from their own practice list. So it does take time to build their practices. We have looked at other places, and we know sometimes it takes up to about a year for a new physician or another provider to build their full team. So we do know that it takes time. We also have seen that by the addition and building collaborative family practice teams, it's helped to stabilize a lot of our areas, a lot of our communities in Nova Scotia, where we've been able to keep our family physicians, maintain the number of people that they're currently seeing, which perhaps they were having a difficult time. So there's a combination of both taking people off the list, and like Jonathan said, over 110,000 people have found a provider, 6,300 a month in the last year. And it also is helping us stabilize some communities. Thank you.
Order. Time has elapsed for the PC Caucus. We'll turn it over to the NDP for Ms. Martin.
Thanks so much. So I too have some background comments, so I'll go through those and then ask questions after that. And specifically, when we talk about doctor recruitment, one of the biggest problems we are looking at to solve is the lack of access Nova Scotians currently have to primary care. Thousands of Nova Scotians are still on the waiting list for a family doc, and those who are lucky enough to be on a roster often wait for weeks for an appointment. People aren't getting the care that they need, and they're not getting the continuity of care that they deserve. We are fundamentally interested in primary care in ensuring Nova Scotians are able to access diagnostics and treatment in a timely manner. Collaborative emergency centres are one of the ways of doing this. The NDP government established 8 CECs in Nova Scotia before the Liberals came to power in 2013. These centres allowed residents to access same-day, next-day primary care appointments during the day and emergency care overnight with physicians and EHS. In a 2014 evaluation of CECs, found the patients at CEC sites had better access to primary health care services than they did before the centres were put in place. And the patients were far more likely to have access to the right provider at the right time in the right place before the CEC was introduced. So I'd like to ask somebody from the department if they could comment on the experience of collaborative emergency centres and how Nova Scotians use them to get, how Nova Scotians could use them to get primary care.
Would that be Ms. Edwards? Ms. Edwards? Ms. Boutlier? Dr. Boutlier?
Did you want? Okay. Do you want the department or NSHA to answer? Okay. Okay. One of the things about CECs for us that has been a challenge since 2015 is the staffing of the CECs and finding family physicians that are interested and in doing both emergency care and primary care. Prior to 2015, the College of Physicians and Surgeons in Nova Scotia had a program called the CAP program, which was a clinical assessment program for physicians that came in on a defined license. The CECs were almost exclusively staffed with physicians that went through this program. When that program ceased to exist in 2015, we had a problem with replacing those people as they finished their 4-year commitment to Nova Scotia. They would get their full license and go off to different opportunities in other provinces. It's been recognized by the college since that happened that we've had a problem with getting family physicians in the province that, what we call a defined license, not in full licensure. And there's been a program established called the Practice Ready Assessment Program that will have that similar type of thing where people will come in and work with other physicians and be able to gain a license on a defined license. And then the opportunities that exist for the people, it'll help people bring people into their practices. People that participate in this program, they can't go to the same site where they train, but they can go to another site that had another trainee. So we have a new pathway for that would help. But that, with collaborative emergency centers, that was a big thing that had changed between 2013, 2016, around our ability to staff.
Okay. Ms. Martin?
So has the department done any analysis on how CECs support physician recruitment attempts?
Dr. Mary?
May I ask Mr. Grant to answer that, please?
Okay, Mr. Grant?
With respect to CECs, I am not aware of any analysis that we have undertaken with respect to CEC's direct correlation to physician recruitment. What I would echo is that we have started the Practice Ready Assessment program, which has 5 people going through it at the moment, and that will continue into the future as well.
Ms. Martin.
CECs have been put in place in PEI and in Saskatchewan. Could anybody speak to how the physician recruitment has been dealt with in those provinces?
Dr. Mary?
So specifically, no, but I have had discussions with the Dean of Medicine at the University of Saskatchewan regarding some aspects of what they've been doing, trying to provide care to rural Saskatchewan, but specifically as to CECs, no.
Ms. Martin.
Has the department done any financial analysis or modeling around how much money CECs can save the healthcare system by providing primary care in that setting?
Dr. Mary?
So I think you referenced in your background remarks an evaluation of the CECs. That had some elements of financial analysis in it, but that's the latest one that I know of. I have been in discussions with Dr. David Petrie, who is head of emergency medicine province-wide for NSHA, and Dr. Petrie has been discussing with me CECs, but I don't have a detailed answer to your question in terms of the economic analysis. I don't know if my colleague, Dr. Boutelier, would have more information on this particular point.
Dr. Boutelier?
I'm just looking here to Grayson to see if he has financial information on CECs. Yeah. We'll have to get
Okay,
it for
can you have that sent? The clerk will send out a letter with a request for that information. Okay.
Nice.
Ms. Martin.
Thank you. Yes, and anything like that we can just receive at a later date would be great. So we have a lot of testimonials from healthcare workers, from patients, from physicians, where CECs work. We see that it's going in moving forward in other provinces, and in Nova Scotia we seem to be going backwards, and people wonder why. Why are we started it in Nova Scotia, now it's going backward in Nova Scotia. Can anybody comment as to why?
Dr. Mary?
Well, I'll go back to Dr. Boutelier's comments to you a few minutes ago, which did explain why we went backwards. So not planned, but something that happened in terms of a particular group of physicians who did staff these emergency centers. I will go back to Dr. Boutelier so she can explain to you the efforts that have been made to staff them, and there have been many efforts and a sustained effort to do that.
Dr. Boutelier.
So we have, I just want to clarify, we have excellent primary health care happening at a lot of the CECs. The CEC closure that you may hear of has more to do with the emergency part of the visits than the primary health care. A lot of the collaborative practice teams do exist within CECs in providing primary health care, so that has not stopped. One thing with the overnight model that had been noted with the CEC is that there wasn't a whole lot of people coming overnight. Like the primary health care actually addressed a lot of the issues that were going on in the CECs. We've been able to stabilize staffing to a certain degree in some of the CECs, but it came down to sometimes provider preference as to what they're doing. For instance, a new physician coming out, they may be a native of the town or area where the CEC is located. They very much want to practice in the place where they grew up. However, they don't have an interest in doing emergency care as part of their practice profile that they've created. So we've had some challenges around that in terms of matching the right people to the right place and still being able to provide primary health care. So some of our CECs have very much had flourishing primary health care and stable primary health care. Others that we've had challenges at with staffing have been enhanced by other health providers like nurse practitioners. For instance, in the Parsborough area, we have a physician and there's, I think, 4 nurse practitioners associated with the different areas there to get out to the different communities. So we've adapted sort of the original CEC to fit the needs of the community so we can provide access like to places like River Hibbert in that situation. And one thing about the CECs also was, because it was brought in under a time when there was different health authorities, not every CEC was created equal in that the expectations at each one and how they staffed them and how it was run was not exactly the same at each one. It was adapted by the different areas and how they ran.
Ms. Martin.
Thank you. And while I appreciate your answer for those communities who have an ER closed, although there may only be 2 or 3 visits or calls per night, they sometimes were life-altering or threatening conditions where the CEC overnight process definitely helped in those cases. But I'd like to clarify, if you could, or if somebody could, if the new Practice Ready Assessment Program will help with the staffing for the CECs, and also what is the proportion of CECs that are doing well as compared to those that could be struggling?
Who wants that? Dr. Boutlier?
I'll try to address some of it. Just to go back to your comment, our EHS system, as well as the rest of our emergency system, is a well-integrated system with closures or not. We make every effort to maintain those connections with different communities, around closures and that type of thing as well. So I want to make sure that everybody knows that the emergency system is there for everyone, regardless about their own community. I understand the conveniences in that, but that people that need life-altering treatment absolutely should be calling 911. The second piece about the Practice Ready Assessment, we have 5 communities now that are, and I'm trying to remember each one that has them. And some places are where CECs are and some aren't. So it won't necessarily just be for CECs. I don't want to give that impression either, but it's another avenue for family doctors to be licensed in this province. And there will be a percentage of those, just like there is in the graduating residency classes, that want to pursue emergency medicine as part of the scope of practice of what they do as a family doctor.
Ms. Martin.
And I'm sorry, did you address the difference between how well some are doing and why some are doing so poorly?
Dr. Boutlier.
I'm assuming you mean in terms of closures. Mm-hmm. There are different ones. We can get you closure information that's available readily on our website. Like we publish everything on there. I couldn't speak to which one has been closed more over the summer or anything like that right off the top of my head. I know I come from the northern zone, and part of our challenge was to provide locums as often as we can to prevent any closures. And it's very clear that emergency physicians we need to attract more emergency physicians in general. Whether an emergency room is an emergency room that's located in a big center or a little center, those physicians need to have the same skills, because people can come into the emergency room with anything. So it's that level of training and expertise that we have to have a concentrated effort on in terms of attracting more emergency physicians.
Ms. Martin.
Thank you. So I'd like to move on to workload issues. According to a recent survey conducted by researchers at Acadia, 50% of doctors reported experiencing symptoms of burnout. The researchers characterized state of physician workforce in Nova Scotia as fragile. We know the department is focused on recruitment, but what seems to be obvious is that retention is just as important, as well as when you talk to doctors on the ground, they say the work-life balance isn't as the NSHA or the department says it is, because when I talk to a neurologist in Cape Breton, and they are the only one there, and they are on call 24/7, there is no work-life balance. So, and while I appreciate you're trying to recruit them, saying that come here and play in Nova Scotia because it's a great place, and it is a great place to live and work, but how do you justify that there currently is a very severe lack of work-life balance? How do you rationalize that in terms of retention?
Who would like to take that? Dr. Boutlier.
Thank you for the question. It's certainly burnout, workload, work-life balance is a critical question right now for physicians, both within the workforce and the people that design it. The Canadian Medical Association has actually instituted a program in the last few years, a conference just around physician wellness to make sure that people are, bringing this to the forefront. And it's something that's on our radar in terms of exploring further as a medical affairs portfolio, in terms of having an actual, like some provinces have gone ahead and developed strategies, like a full provincial strategy and things like that. I'm not sure if you're aware, but I did this job a little bit as an interim, as shared position, recently just came in the job in July, and we've had a meeting recently with our senior leaders around these type of issues about how, as a group of leaders, we want to move forward with some of the more overreaching themes. Certainly work-life balance, when new physicians are coming, that is something they look for right off the bat. And, some of these team environments that we're able to create, and that addresses some of those issues to a certain point. People that have been in practice a long time in the communities, and, they have very challenging call schedules for years and years, like 1 and 2, 1 and 3. It's the way they worked. Like we talked about earlier, the stress of the aging workforce, as well as complex medicine. Like, medicine's gotten a lot more complicated. It's not the same as when I started 20 years ago. It's not the same as when Dr. Mary started. Like, every year the complexities have changed, and it does take a toll on physicians. So alternate providers as part of teams has been a source of something that we've done. Retention efforts, we are really looking to the communities to help us with that as well, because we found, like you say, like, there is a lot of great places to come in Nova Scotia, but are they great places to work? And we really are turning more and more to our physicians in the community to really address those issues when they're attracting people there as well, so that people know what the community can offer them and what they can expect for their work life, and how people make compromises with each other when you're parts of groups, in order to provide the best service to the patients in your area, as well as having a reasonable work-life balance. Some of the things that we've had with the Department of Health that we've looked at is locum incentive programs and the locum program, which is quite different than other jurisdictions, in that people have a certain number of days that they can access in a year to get a time away for their practice, and it's really important for people to take that time away.
Dr. Mary?
Thank you. I would like to add one thing and then ask Mr. Grant to add something else that the department is doing. So Doctors Nova Scotia has a program to try and help doctors who are under stress in terms of workload. And Dr. John Chazon, a well-known figure in Nova Scotia, runs that program. And Mr. Grant will mention, if he may, what the department is doing.
Okay. Mr. Grant, there's about 2 minutes left.
So thank you for the question. I think it's a really important question. One thing that the department has undertaken in the last few months is a red tape reduction program. We are doing that in concert with the Office of Regulatory Affairs, and they are doing some analysis on some of the red tape that exists for doctors, which may or may not contribute to the burnout.
Ms. Martin.
Thank you for that. And while that is, all well and good, but the community can't help take away the workload of the physician. We know of cases where we've had physicians looking to have a part-time family practice and a part-time schedule that the NSHA and or the department, because I'm not clear, has not accepted that offer. So when we're looking at, I just recently spoke to a doc who's here on a locum, and she said, with the work-life balance, it is not in her best interests. And when other docs hear of people coming and saying, well, I'd love to have a part-time family practice, I'd love to do a part-time emergency room schedule, and they're being told no, then these people are being discouraged. We can offer them all the parties that they want, but we can't help them with the patient load that they see every day. And it may be different in HRM, it may be different in the northern zone, but I can tell you in CBRM and in the eastern zone that these physicians, when they're one or two of, they are working full stop, no breaks, and people are not coming there because they know there is no work-life balance.
And that's for?
Time's up.
Oh, it is almost up. Okay, we'll turn it over to the Liberal Caucus for 20 minutes. Mr. Irving.
Thank you, Madam Chair, and thank you all again for being here. And I want to thank Dr. Mary for coming out of retirement and stepping up to play the interim role as Deputy Minister. And we're very fortunate to have you both with your years of experience, but your relationship with doctors and the university, which are key partners in us working on the challenges within healthcare. I'm going to focus my questions primarily on primary care practitioners and how we recruit and retain them. And I want to begin by helping us and Nova Scotians best understand the challenge that we've got, because there's all sorts of numbers out there that can be interpreted in different ways, and perhaps you could shed some light on this. I mean, the Canadian Medical Association shows that Nova Scotia is the third best in the number of doctors. I've seen other stats that put us as the fourth best province in the country. CAIHI has shown over the years, particularly the decade between 2005 and 15, we had more doctors per 100,000 than any other province. And CAIHI stats show that Nova Scotians have access to care above the Canadian average. In the last election, Information Morning, Anna Marie Tremonti did a piece on access to physicians, where Nova Scotia was at 10%, BC was at 15%, and I understand Quebec is actually 25%. And these are Stats Canada numbers, and of course they are different than the numbers we're using with the family practice list. I would assume that list at 52,000 is probably fairly accurate, as we know that there are many 20-somethings that are living forever, so they don't need doctors. But, and this, I'm not trying to alleviate the concern, of the 1 in 20 Nova Scotians that don't have family doctors. But I was wondering if someone could comment about how we are relative to this worldwide shortage of doctors and the competitive nature of doctor recruitment. In other words, it would appear to me that Nova Scotia has actually done very well over the years, but because of this tightening worldwide, the competition for doctors is we're needing to fight and work harder at this challenge, because so many other jurisdictions are actually worse off than we are. Could someone speak to where we stand relative to the worldwide shortage of doctors and the competitive nature of this?
Dr. Mary?
Thank you for the question. It's a long preamble, but probably an equally long answer if I have the time. So let me start on a world basis first. So if you look at the OECD countries, the target for most of those is to achieve less than 5% of people without a family doctor. So France, Germany, the UK are around the 5% mark. The US is actually a lot worse than we are. There's only one country in the world that I was able to find in doing a literature search on this that has none of its citizens without a family doctor, and that's the Netherlands. And I'm not sure how they counted their numbers. I tried to find out, but I unfortunately don't know anybody in the Netherlands who could give me that answer. But so if you look at most of the rest of developed countries, a target to achieve is somewhat less than 5%, but important to have care available when you need it. The absolute numbers, though, are not the only thing one needs. In a province such as ours, in particular, distribution of physicians, so urban versus rural, is a key piece, and one always has to keep that in mind. The other pieces that we haven't talked about today, so in an ideal world, you would like 50% of your physicians to be specialists and 50% of them to be family physicians. So we haven't touched on the specialist component at all, and in terms of recruiting to that sector of the physician population. That is also important, because one of the things that we actually do well in the province is to be able to provide good quality tertiary and quaternary care. So there are very few things as a Nova Scotian that you have to be referred outside the province for. The expertise is here. In no small part, that's due to the fact that we have a medical school. So in attracting the specialists, you want to have an environment where they can do research and have state-of-the-art facilities available to them. So having NSHA and IWK facilities with the type of equipment they need is really critical. And the Cape Breton redevelopment project and the QE2 redevelopment project certainly assure a bright future in that regard. I want to turn for a moment to something that Dr. Anderson covered briefly in his remarks a few weeks ago, but I want to give you my experience with a program which has the acronym LIC, Longitudinal Integrated Community Clerkship, and we're starting one in your riding now, Madam Chair. Mm-hmm. With that program, and I started that in for Northern Alberta when I was Dean of Medicine at the University of Alberta, because Northern Alberta had exactly the same problems as rural Nova Scotia. You could not get a family doctor to go to rural Alberta. What communities did there is they would travel to the UK, have a recruiting fair, eventually come back with a doctor. 2 years later, that person was gone. It cost them $200,000 per year for a doctor $200,000 for the 2 years for the doctor, because they also provided free clinic space, free housing, and so on, but it didn't work. So with some help, I borrowed from the Outback in Australia, where they introduced a program that if you take third-year medical students who think they're interested in a rural lifestyle and want to practice in a rural community and set up their curriculum so that they spend all of third year in that kind of a setting. Now, the community has to be big enough that they satisfy their educational requirements. If you do that, the experience from the Outback and from North Dakota was that 50% of these students go back to a rural community and spend their entire career there as either a general specialist, so a general surgeon, general obstetrician, or as a family doctor. So it's now about 18 years ago since that program started in Alberta, and it's performing exactly the same way as it has in North Dakota. 50% of the students are going back to these communities. At the end of the year, 50% of them decided it's not for them. So that's been one of the few interventions that's been proven to work. Unfortunately, it's a long-term strategy, so it doesn't solve your problems today. Long-term, it will solve the problems. When I referred briefly to an increased number of medical seats, which Dr. Anderson did as well, but I didn't point out that in terms of the residency programs, with the number of seats there, the number of positions for emergency medicine were increased, both in the family medicine stream, because there are two streams in emergency medicine for training, You do 2 years of family medicine and a year of specialization in emergency medicine versus the Royal College program, which is a 4, maybe 5-year program in emergency medicine. So we did increase the number of residency positions there. In subsequent conversations with Dr. Petrie, and I haven't discussed this with any of my colleagues yet, he's of the opinion we need to increase that even further. So I'm conscious I've gone on at great length to try and answer your question. There are other elements to it, but I think I better stop so you can have some more questions.
Mr. Irving.
Thank you, Dr. Mary. With respect to recruiting doctors in this competitive world that we have, I just want to comment a bit about the importance of the narrative that we have in Nova Scotia with respect to the challenges here. And I heard from a doctor recruitment a recent story of taking a doctor into a community, and they were having a look around, and the doctor opened the local paper to a hugely negative story about healthcare within the area. And at that point, he said, "Let's move on to the next community." I think that is a message to all of us as Nova Scotians of the importance of us laying out the positives that we have in Nova Scotia, and I think communities stepping up now, as you alluded in your remarks, are now playing a much bigger part in creating that more positive a narrative about the communities that we're trying to attract communities or doctors to. Yarmouth municipalities are stepping up with funding, chambers of commerce, and you mentioned what happened in Kentville recently, where the chamber, brought in businesses with donations for welcome baskets. And that was a very positive news story that actually I heard in Ontario recently on the national news. And so these things are important. So we have a new fund now to help communities get involved. And Tina Henniker, of course, as you mentioned earlier, or Lunenburg now. I wondered if you could comment on how important it is for communities to get involved, taking advantage of this new Healthy Community Stream Fund with CCH. What MLAs can do, what communities can do to help us attract and retain doctors.
Dr. Mary?
Thank you for stressing an area that's very important if we're going to be successful in achieving what we need to achieve in healthcare by having the right number of providers in the right spots. In my opening remarks, I think I had one sentence that we all have to work together to make this happen, and that's very clear. So you represent the best interests of your constituents, and I think it's important that we hear that, but it's an effort overall. Healthcare, while we have lots of issues, and your point goes out to us today, and lots of room for improvement. But consistently, once you achieve access to the system, the results are very good. Grant you access as a problem. What I think is also important is some balance in how we portray the results of the healthcare system in the various vehicles that we have for public communication. So that becomes important, and it really is establishing the tone of how what the tone is of healthcare in this province. So that's important as well. But I would like to re-emphasize, if we don't start to work together, we're not going to get to where we need to be.
Mr. Irving.
My next question is with respect to international recruitment. I'm working with the Annapolis Valley Chamber and 3 municipal councillors on how we can do more in contributing to the work of NSHA and the recruitment and retention. And just last week, I had the opportunity to tour a UK physician around for an hour or so. And it was very insightful to not only show off what we have to offer, but in terms of what they were interested in. And what one moment that I thought was poignant was he turned to me in the backseat of the car and said that we will see many more physicians from the UK in Nova Scotia in 4 and 5 years. He saw the real opportunity for us of recruiting physicians. He said physicians in the UK have traditionally looked at Australia and New Zealand, and Canada is now on their radar. And he pointed actually that Nova Scotia has a competitive advantage in our direct flights and our relationship. We're not that far away time zone-wise and physically. So I thought that was helpful. Could you comment on the international comment on the international recruitment activities and how much effort is being targeted to the UK? And do you agree that the doctor I spoke with, that there is a significant opportunity with respect to UK doctors?
Dr. Mary?
Thank you. I will start, and then I will ask Mr. Grant and Dr. Boutelier to follow on. So thank you. You've pointed out something that's where things are going really well lately. The department has worked with the Department of Immigration to make sure we can streamline that process immigration-wise, and Mr. Grant will comment briefly on that, and I think Dr. Boutelier, if I may, Madam Chair, would then round those comments out about what's happened on the ground with respect to the success that we've had lately.
Mr. Grant?
So to speak to the permanent residency, we have started an expedited process for physicians coming from abroad to get permanent residency on an expedited basis here. I'll turn it over to Nicole or to Dr. Boutelier to talk about international recruitment specifically. Dr.
Boutelier.
Thank you. And I'm going to let Grace Fulmer talk about that, who's been most closely involved.
Mr. Fulmer.
Thank you. So first off, thank you for participating in the site visit. It's most key and most important to have local community members demonstrating why their community is where this physician should locate. We have recruiters spread all across the province, but I cannot highlight the importance enough of having local people, local physicians, local community members participate with that process to really demonstrate the unique aspects of why they should be living and working here in Nova Scotia. I want to take this a little bit step back and talk about all of the components that had to go into place to have that physician from UK touring Annapolis Royal and area. First of which, and Mr. Grant talked a little bit about this, is we do actually have a competitive advantage here in Nova Scotia around our immigration process. We're one of the...
Excuse me, could you just speak up a little bit more? People are having a challenge. It's
Pardon
the
me.
fans.
Is that better? Thank you. I will try to project if I do not. Just raise your hand again. So first of which, after we've worked collaboratively with the Nova Scotia Department of Immigration to establish a physician nomination program. That's unique across Canada. It's one of those core attractive points that enable our ability to go out and recruit internationally, where we can have physicians come here faster than most other jurisdictions. The other key point that I want to make is our College of Physicians and Surgeons. One of the core changes that they've made to licensure is that they actually recognize certain jurisdictions and training and experience from certain jurisdictions as comparable to Canada, which eliminates a major barrier to the mid-career physician, which is challenging their exams. So those two combined competitive advantages here in Nova Scotia make the UK an excellent recruitment place for us to move into. We also have a geographic advantage relative to the rest of Canada, as you spoke about. It's a 5-hour flight to London, which makes it extremely attractive to the UK physicians to relocate here. We've made significant investments in trying to recruit internationally, as well as UK, Ireland, and to a lesser extent the US. We've moved into that market in terms of marketing protocols, generating a lot of interest in coming forward. And then we've been able to connect our UK physicians or physicians who have immigrated from the UK, one of which is Dr. Bonington in Annapolis Royal. He's been an extremely strong advocate on our behalf, and make those connections locally so that physicians can recruit physicians. We've established this program and our international presence really in 2017, and our first few cohorts coming through, we had a lot of feedback, hearing what went well, what didn't go well. So now we're moving forward in terms of trying to address and streamline that process even further, making sure that we're addressing where those concerns are and continuing to market on our competitive advantage while moving forward and trying to get people in the communities where they best match.
1 minute. Ish.
Thank you. I probably won't go on to my next question. I did perhaps just want to give a bit of feedback. I was going to do this offline, but since I have a minute here, and I'm not sure if you could direct it to whoever needs to be directed. I think one thing that can be improved upon with respect to communities' involvement in the recruiting process is more notice and information to communities about the doctors, their families. I think there's some room for improvement there, having been involved in it, and I just want to pass that along, that I think that could help enhance the work that we're all doing together. Thank you very much.
Dr. Mary, very quickly.
So very quickly, so I've asked Dr. Ray LeBlanc, who's a retired ophthalmologist, to work with communities to help us to optimize that process.
Order. Time has lapsed. We'll turn it over to the PC Caucus for 8 minutes.
Thank you.
Mr. Hellman.
Thank you, Madam Chair. 11 years ago, when my eldest child was born, I recall, when you call your family doctor, it would only take a few days to get an appointment. It's my understanding a few years ago, even up to a few years ago, 50% of doctors were able to provide care within 5 days. And I'm hearing, anecdotally of course, it's becoming more and more challenging for parents and guardians, if they have a family doctor, to get an appointment with their family physician. Oftentimes it takes up to 3 to 4 weeks. In our community of Dartmouth, as my colleague would know, that often manifests itself in parents taking their children to walk-in clinics. I'm curious if the department has any statistics on whether or not they know how many patients have to wait 2 to 4 weeks in order to get a regular appointment.
Dr. Mary?
So I'll answer your question from some personal experience in visiting a number of clinics around the province, and then Dr. Alexiadis, in fact, has been working on that problem in her practice, and she'll tell you firsthand what she's been doing. So I did visit Clayton Park West, which is a private practice facility in Clayton Park. I think 6 physicians, extremely well run, and they recognized the problem that you just alluded to, that they found their patients they couldn't see their own patients as quickly as they would want when they had a problem that they felt needed to be addressed that day or within a day or so. So they actually started a walk-in service for their own patients, which has actually started to work very well. But Dr. Alexiad has recognized that issue and has actually done something about it.
Dr. Alexiadis?
Thank you very much for that question. I think it's very important to first recognize the fact that the physicians in this province have been providing care every year when new changes have happened and more struggles have happened. They've always stepped up to bat to do that care. It's getting harder because medicine is getting more complex. Patients are getting older. Patients also have more illnesses. I've been in practice over 30 years in this province as a family doctor. So I remember the days where a patient could come in 2 days and see me, up to 6 weeks were sometimes my wait list, because I also have interest in mental health. So what we're talking about here today is about collaborative care teams. So we have opportunities now to look at the healthcare that we provide in primary care, increase the flexibility and the adaptive nature of family practice in order to be able to address those population needs. So in collaborative care teams, what you're doing is you're actually creating teams where you have the right person, the right provider for the right treatment. So for example, if you have a team of physicians and you add a nurse practitioner, a family practice nurse, then the patient comes to their health home. So I'm using a term that we're now alluding to, talking about health home. So the patient may not have a specific doctor all the time or a specific nurse practitioner all the time, but they come to a practice where they know that they'll get their needs met. The difference between doing this health home where you see different providers versus, say, a walk-in clinic is there is the health home has all your health information, whereas in a walk-in clinic you'll go and they may not have your past history, your allergies, your medications. The health home will have that because they'll access through the technology that we're now using, which is the electronic medical record. So I'll give you an example. Say someone who comes in, they want their blood pressure checked. So in the old system, I would see the patient, do their blood pressure. If it was good, I would give them their prescription, have them come back, or give them advice. In a collaborative care team, I may not have to see that patient all the time. The family practice nurse could, in fact, do that blood pressure check, leaving me time to have another space open for another patient to come in. Currently, we don't have teams across the province. We have 84 teams, hopefully by the end of the year, 88 teams. But doctors right now, what they're trying to do is create same-day, next-day access appointments. There's a lot of physicians that are solo physicians or in family practice, just their own groups, where there's doctors who they do try to accommodate their patients. So it's just the fact that we have these opportunities now to open up, become more adaptive, and recognize that by looking the status quo and pushing it to the side and saying, let's see what we can do and what opportunities exist, you will see that there will be that opportunity to have more patients seen. Not only that, the previous question from your last set of questions talked about, emergency visits. You're going to have less tertiary care because in those teams, it's not that you'll see the patient for a longer period of time, it's that you'll see the right provider for the right time, as well as having issues of your risk, lifestyle risk management, preventative care, as well as doing the acuity of medicine that we always have to do, and chronic disease management. So that's why, for me, these are the opportunities that we have, and we need to move forward and invest in primary care, which is the backbone of the healthcare in this province.
Dr. Mary.
Provide a more direct answer to your question. Ms. Edwards has designed one of the 28 criteria for collaborative care teams, which is on exactly that point. And Madam Chair, if I may, would you ask her to answer that question?
Ms. Edwards.
So thank you for that. And as Dr. Alexiadis has mentioned, the development of collaborative family practice teams, we have required as we develop teams for those providers to come together and identify how they're going to address people who have urgent care needs in the population that they serve, and we're in the process of monitoring that. So we do expect as we add more providers to a collaborative family practice that opens up some opportunity. It's quite a business to run a practice, and it's actually office efficiency, which is another component of running a family practice and a collaborative team. So we have actually been able to assist some teams in a quality improvement where they've actually looked at how do they see people, how many people do we have to look after, and how can we improve that? And so we're in the process working with a number of teams right now on that particular endeavor. So it's been identified, it is an issue. We want our teams to be able to see people who are urgent when they need to be seen.
Mr. Halliman.
Madam Chair, so am I correct in saying we don't have a quantitative measurement of how many people are, how difficult it is for some people to access a family doctor? If they have a family doctor, it's more qualitative. We know anecdotally that there are issues, and you're saying that this is something that we're working on. But this isn't something we're specifically measuring. Am I correct in saying that?
Dr. Mary?
So, no. We're not measuring as well as we would like, but we are measuring it, and we haven't, and so that's what Ms. Edwards was discussing. That's one of the 28 parameters that's being looked at within primary care teams. A challenge now is to go beyond that to look at the entire province, and I guess in that sense, we don't have that for the people that are not in the collaborative care teams.
Mr. Halliman.
Thank you, Madam Chair.
30 seconds.
All right. Madam Chair, I'll bypass the question, obviously, for 30 seconds. Certainly, a comment that was made by the Deputy Minister that care when you need it. I know we're all sort of united to make sure the system is there for patients when they need it. I mean, obviously we know that there are great challenges there, and certainly the question I asked, I think, illustrates that an area where we definitely need to improve.
Order.
Right,
Time has lapsed. We'll turn it to the NDP Caucus. Ms. LeBlanc for 8 minutes.
Thank you, Madam Chair. I'm going to talk really fast because I have a lot of things to ask. I wanted to say thank you for your answer, Dr. Mary, about the balance we need in terms of good news stories, bad news stories. We got to call a spade sometimes, but we also, we do need to celebrate the successes, but we also have to look the problem in the eye. And I think that from the outside, I think looking the problem in the eye and the good news story becomes, look how we are seeing this problem and dealing with it. That is the good news the story. And I am encouraged when I hear talk about the link strategy and what's going on at the medical school, and all of these things seem very exciting to me. So, but one of the things you also said in that comment was we need to be flexible. And so I want to pick up on that and ask a question about a doctor named Dr. Donald Curtis. So in theory, and I will go back to this if I have time, I think that the collaborative practice teams are I'm sold. Sign me up and sign Dartmouth North up. But we know that there is more to it than that. We know that those teams work really well, but then we're in this system that has a bunch of different systems going on. So at the end of August, Dr. Curtis announced that he'd be closing his practice at the Weymouth Medical Center effective November 30th. In his notice, he talked about he got a letter from the NSHA terminating his existing APP contract and offering him a new contract with different conditions other than the ones he was practicing under, and he chose not to accept the new contract. He could have continued practicing in Nova Scotia under the fee-for-service, but he did not have the financial reserves or the emotional and physical stamina to continue practicing under that model. The Weymouth Medical Center, where Dr. Curtis practiced, was connected to the Digby Collaborative Practice Team. So I understand you can't talk about individual cases, of course, but I'm wondering if a representative from NSHA could explain if it is common that at the health authority to alter contracts or to change contracts in the middle of a contract when, the APP ones, when a physician is practicing, under which a physician is practicing.
Dr. Boutlier?
That letter, contracts are managed by the Department of Health for APP, so it was a letter from the Department of Health, so I'll have to redirect.
Dr. Mary?
Thank you. I'm fortunate to have Mr. Grant with me who administers these contracts.
Mr. Grant.
So thank you for the question. I think it's an important question. Obviously, we can't speak to specifics, as you said. I think from the perspective of contract management, I don't think it's common for us to change contracts in the middle of a contract. That isn't something that we traditionally do. And we do look to try and find flexibility for physicians where we can, ensuring that patients get care in Nova Scotia.
Ms. LeBlanc.
Thank you. So can you talk about, I'm glad to hear that it's not common practice, and you can't tell me why this, in this case, this happened, but just a quick comment on, your view on whether or not you think that this kind of practice is helpful for physician recruitment.
Mr. Grant.
So I can't speak to specifics. I would say that we are doing a lot of really important work on recruitment in this province. The circumstance that you're discussing in this instance is not something I can speak specifically to. I think we've made great strides with recruitment, and we continue to focus our efforts on incentives and keeping physicians in this province.
Ms. LeBlanc.
So going back to the flexibility issue, I was just talking to one of my MLA colleagues about this, that in many departments or many sort of services that the province provides, we sort of run as though it's 40 years ago. Not to say that this is what's happening at the health authority or at the department right now, but, if, for instance, women, when things like schools are canceled because of hurricanes, for instance, that the jumping around and trying to figure out who's going to take care of the kids, that often falls to women or the primary care provider for a child. And it feels like sometimes things can't be as flexible as they need to be. So can you talk a little bit about what the health authority is doing to ensure that there is more flexibility for people who want to work in different ways. Maybe doctors want to work part-time. What is being done to accommodate people who want to work in different work models?
Dr.
And for lots of good reasons.
Dr. Boutlier?
Thank you. I understand those complexities. I have no power and 3 children, so I know the problems of hurricanes and others. You know, a lot of times when it's hard to have one pat answer for you that every situation would allow there to be a half-time person or this, and like what I can say is that our leaders are working with individuals and teams and departments to figure out the way that the complement of their physicians can achieve the results they want to achieve and have the lifestyle that they want to have within that group. So can I give you a couple of examples to illustrate this? The department in Truro had 2 male and 2 female in their radiology department. And the female physicians wanted to cut back on the time that they worked. So they worked with the leaders in that department and with the replacement committee to put a proposal forward that they were going to reduce their workload by X amount, and that would allow them to hire someone else at X amount of an FTE. And they had a person they recruited, and they did that. And it worked out for them, and the department agreed, and everybody was happy with that arrangement. So it's working internally with the departments, with the processes we have to create the conditions that people want to improve their work-life balance. And it's not the same for every department.
Ms. LeBlanc.
How much time?
1 minute.
Okay. I just want to go back quickly then to the collaborative team, the collaborative practice teams, and you know, you make a great case for them, and I want to know if this is the way of the future, then what is the ask of the NSHA to the department for the upcoming budget year? Are you going to ask for continued and more funding to establish more collaborative practice teams around the province?
Who wants to take that? Ms. Edward?
Yes. So in a word, no. So we've had an investment already to date, as Dr. Mary has identified, the $58.4 million, which has allowed us to increase our primary care team. Like, our staff increase has been 150% over the last couple of years. So, and we've seen the impacts over time that that's starting to make. We will continue to look at the investment going forward and put in our business case as usual. We know that in order...
Time has lapsed. We will turn it over to the Liberal Caucus for 8 minutes. Ms. D. Costanza.
Thank you, Madam Chair. And I'm happy that she ended it with the collaborative care, because that is the most exciting thing for me, to see the number 80 collaborative cares. I have worked at the 5 years ago, it started with the, I believe it was Tim Holland, the refugee clinic was the biggest collaborative care. And I would love to give a lot of the details that I saw, but definitely the efficiency and the work atmosphere that collaborative care brought for the doctors themselves, the patients, was wonderful. And I have an amazing doctor who has his own clinic, and I honestly wanted to move to be with that, because I would be called as an interpreter to work one day with the nurses, one day with the diabetes, the dietitians, and they worked so well together. Also, I know that one doctor brought the other. They brought each other, with 5 of them from the same year, graduates from the same year. So it helped bringing the other, and they worked in an incredible team. The efficiency of that collaborative care was really renowned, in my opinion, and I'm hoping that this is what is happening with collaborative cares. So I would like to ask the question is, what is collaborative care? For this one had just a dietitian, nurses, and this, and what are your hopes for the future? You have 80. How much of our, a 5-year long-term or a 5-year plan of how many do we hope to have, and how do we set them up across the country? Because I don't think each collaborative care is equal in different parts of the province. If you can explain that for us.
Ms. Edwards?
Okay, so thank you for the question. You're right, we did start with 39 collaborative family practice teams, and now have, at the end of this year, we'll have 88. Those teams, when we say a collaborative family practice team, we're talking about 3 providers, 2 of which are from 2 different disciplines. And that would represent a small size of a collaborative team. And in some parts of our province, that's who's there in that small rural area. We also, our teams will vary in size, so we'll have some very small ones, some what we call medium size and larger. We know that that what we have done is we've increased the number of nurse practitioner seats through Dalhousie. So for some of the hard to recruit to areas, we'll be having 10 seats that will be filled in those areas. We'll be adding to strengthen our teams that we have now. And we also have incentives for our nursing staff. And I also want to mention that our nurse practitioners, we've been successful in recruiting about a quarter of those nurse practitioner positions from outside of Nova Scotia as we continue to educate provide more nurse practitioners in the province. So a team may represent a group of family physicians along with a nurse practitioner. There will be a family practice nurse and also other providers. We call them community adaptive team members. We're not there in all of our teams. We don't have all of those people in all of our teams. So our go forward plan, and sorry, I'll go back to the community adaptive team members may be pharmacists, they may be dietitians, they may be social workers, and we've increased the number and we still have more work to do on that. So we'll continue to look at the teams that we currently have, how we link them to the other providers in the system. So if we have solo physicians or group practices that aren't in a team.
Ms. Edwards.
Sorry.
So what we do is we ask the group coming forward to look at the needs of the population that they serve and to identify what is the best professional that, from a scope of practice, what do we need to help serve this population? And we get those requests on a regular basis.
Ms. DiCostanzo.
Thank you, Madam Chair. I'm also wondering, with the new immigration stream, are these doctors requesting to be part of collaborative care, or are they more wanting to be because they're coming with very little established thing? And collaborative care would be a very attractive thing, I'm assuming, but I'm not sure. Sorry.
Ms.
Yeah. I have one more.
Ms. Edwards, or? Dr. Alexides.
Thank you. The easy answer is yes. I mean, collaborative care teams, you said how many? I think as many people that want them, we should have them for them. And there's a lot of physicians here in the province who want them. A lot of our students are trained in team-based education. So they want teams when they graduate. But also the UK doctors, as an example, who came over, were all in teams there. And they are all requesting as well to be part of teams. So I think they even have experience as to how their teams worked. They can share with us as we go forward and create these teams in the province.
Ms. DiCostanzo.
Thank you again. I also had another question in trying to relate community health centers to collaborative care. How do they work? And do they have collaborative care within the community health center? How does that work?
Dr. Alexiades?
I'll start, but someone may want to add. I mean, I'm trying to think of an example in my head, and the answer is yes. I think when you heard earlier how they were set up, where the CAP physicians were staffing them, now they've adapted. So we have other doctors who are not CAP physicians who are working the CECs, and they have a primary care practice, but now there are some that have nurse practitioners that have been added to their primary care clinic and actually offer the primary care piece in those CECs.
Is there anyone else? No? Ms. DiCostanzo.
I also wanted to know, so maybe more of a comment rather than a question is, how are we thinking in taking the load off doctors in certain things because of collaborative care? A lot of the patients who came did not really need to see the doctor. A nurse could deal with the situation, or others. How are we at the front desk when the issue is there? In these collaborative cares, are they able to categorize before they ask to see a doctor? Is that happening in releasing some of the pressure from our doctors?
Dr. Alexander.
You bring up a very important point because this is a new thing. And so we try to offer support to those practices that create those collaborative care teams to see how they want to work together. Because different people within a team have different expertise. Someone may have a mental health expertise. Someone may have a dietitian expertise. So the team needs to sit down together and see who will do what. Will the nurse do some home care? Maybe not. Maybe the nurse practitioner wants to do it. Maybe the family doctor wants to do a little more mental health. So again, we're not dictating how to do it.
Time has elapsed. This is the end of our questioning. I'll ask Dr. Mary for closing remarks, please.
Thank you, Madam Chair. As I stated in my opening remarks, my goal today was to provide information and context for the two topics that you've chosen for us to address. You've heard a lot from Department of Health and Wellness and from Nova Scotia Health Authority on collaborative care and doctor recruitment. It was a good discussion. I hope we met your expectations on the topics that you proposed. The department will endeavor, as well as NSHA, to provide to you any answers to the questions we couldn't answer today. I think you've already asked us for some answers in that regard. While we still have challenges, what has been achieved in healthcare in this province is impressive. Let me remind you that people are living longer, they're able to watch their grandchildren, and even their grandchildren, if they're really lucky, grow up. New technologies are transforming healthcare. Healthcare in the province is being modernized to take advantage of these new technologies and the improvements in care that they can provide. In that light, the QE2 development and the Cape Breton Regional Development will provide us not only with good infrastructure, but also with new equipment, as well as improving the economy and the social determinants of health in these regions. I have left what I consider my most important message to last.
We want to hear it.
My health is my responsibility. Thank you.
Well, I'd like to thank our witnesses for coming. You'll probably be meeting the press just outside the doors. We're going to have a short business meeting, so we'll recess for 2 minutes while you exit the chamber. Thank you. Order. We have a bit of business, but I wanted to allow you to have as much time to ask questions today. There were long opening remarks than we usually have, but they were important to hear. So we may need this meeting extended so that we can carry out the business, because we have subcommittee sort of planning our schedule. So would anyone entertain making a motion to extend our meeting time? Ms. Adams.
Thank you, Madam Chair. I would like to make a motion that we extend the meeting time past 3 o'clock until business is concluded.
Okay. All in favor? Okay, we will proceed. We have a number of correspondences that the clerk, I'm sure they're included in your packages as well as mine, from Ms. Paula Bond of the Nova Scotia Health Authority. Any questions? We also had a correspondence from Dr. Marcy Sachs Braithwaite from NASHA in response to a request for information from our July 9th meeting. Any questions about that? Okay, then we will then go to, and there is also a, there was a letter here with a chart, so that's all there. And we will go to our agenda setting. We should end up with 6 topics, 3 Liberal, 2 PC, and 1 NDP. I think we will start with the Liberal caucus. You can, if you prefer to bring all three together, we can do that as one motion, or you can do it individually. It's up to you. Mr. Irving.
Thank you, Madam Chair. That was my question for you. Let's try to do the 3 together. Topic number 1 would be 811 Nova Scotia, witness being Dr. Todd Howlett, Executive Director of 811 from the NSHA. Our second topic we'd like to propose is the Youth Mental Health Outreach Program, the CAPER-based program, witness being Samantha Hodder, Director of Mental Health and Addictions, Eastern Zone, NSHA. And we'd like to pick up the, I guess, the walk-in from the Canadian Cancer Society, who have written us with respect to youth smoking and vaping. And as you know, the legislature recently worked with them with respect to flavored cigarettes, and this issue of youth smoking and vaping seems very topical and important. So we would like to ask the Canadian Cancer Society and also the Lung Association of Nova Scotia to be witnesses to talk about this very important subject. So I would like to move those 3 topics with the associated witnesses.
Okay, any comments? Comments? Okay. Yes, Ms. Adams.
Sorry, can you clarify who the third topic was?
It was Mr. Irving.
Thank you, Madam Chair. The third topic is youth smoking and vaping. It was a request from the Canadian Cancer Society to the committee, and we felt it important to defer one of our topics to bring that forward due to its important nature and timely topic. So we've made room in our 3 choices to accommodate the Cancer Society.
Okay. So is that a motion, Mr. Irving? Okay.
I did
All
make that
those in
motion.
favor? Opposed? Motion is carried. We'll move on to the PC caucus for 2 topics. Ms. Adams.
Thank you, Madam Chair. We would like to move that the first 2 topics on our list, the pharmacist's role in healthcare and scope of practice, as well as the Doctors of Nova Scotia and the ongoing doctor shortage, as our 2 topics.
Ms. Di Costanzo.
Thank you, Madam Chair. The pharmacist's roles in healthcare, that's wonderful. The other topic, the Doctors Nova Scotia, we would prefer if that can be after the negotiation. It would be inappropriate topic if the negotiations are still on with them. So if we can, we will
Have
still
it
accept
later?
it, but reschedule it to after the negotiation has been completed.
Ms. Adams.
Could you clarify for me exactly when that would be? Because negotiations could go on forever. So do you have a target date for when those negotiations are going to be finished?
I think what we could do is have the clerk put it towards the end of this rotation of meetings, and should they not be able to come in for that reason, you could substitute another one of your topics, would be the alternative.
And just keep pushing it.
So
Yes.
I guess...
Ms. Adams.
So I'm not clear on the reason for, I mean, negotiations are going to be ongoing for quite a while, and the issues of doctor shortages is the #1 critical issue in this province, so I don't understand why we would want to delay it until negotiations are done, because as soon as those negotiations are done, they're going to start working on negotiations for the next time that we go to negotiate. So obviously the Liberals can do what they want because they've got the majority, but since we have no idea when those negotiations are going to be completed, I don't believe that we need to push it to the end of their negotiations unless we have a target date for when those negotiations are going to end.
Ms. DiCostanzo.
And it is totally inappropriate to have those questions that may affect the negotiation. So we will wait until after the negotiation. And it's possible that the negotiation could be over, and the subject will be put through a normal time as their second subject. It should be not a huge issue at the time. They can pick another topic and put that forward as their number 2 if this one if we get to it before the negotiation is over.
Ms. Adams.
Thank you. I'm still not understanding this because the topic is Doctors Nova Scotia and the ongoing doctor shortage, not Doctors Nova Scotia and the ongoing negotiations with the provincial government. So there are all sorts of questions we asked here today that could impact negotiations. We could have asked about the blended model of payment that might affect negotiations. So anything we say could affect negotiations, any stance we take on anything. So I don't want to substitute. So if you're going to not allow this topic to go forward, then I want to call for a recorded vote on not allowing this topic to go forward. So I'm making the motion, and if we don't want to have it included as a topic, then it'll have to get voted down.
I don't think there was a request to have it excluded. It was to put it at the end of the rotation of meetings.
Well, I don't see the need for that either.
Ms. DiCostanzo.
We are not accepting the topic. In fact, no. We definitely would like this topic. It's just the timing of it. We can just delay the timing until the negotiation, and we can deal with it at the time. Yeah. All we're asking that the clerk schedules it at the end of the rotation. That's all we're asking.
Are we ready for a vote? Oh, sorry. Legal counsel has said you may have to make an amendment to the motion to have that go forward, that it be scheduled towards the end of the cycle. Ms. DiCostanzo.
I would like to make an amendment to the motion put forward that we have that topic at the end of the rotation, and it will be the last one that will be heard by the committee.
There is an amendment. All those in favor? Aye. The amendment passes. We will go to the motion. All those in favor? Opposed? Motion is carried. We will turn to the NDP Caucus for their topic. Oh, Ms. Martin.
Thank you. Our choice would be children's oral health, with representatives from the College of Dental Hygienists and the Deputy Minister, Department of Health and Wellness.
Oh, Mr. Irving.
Thank you very much. I appreciate our colleagues bringing this one forward. We would just like to suggest an additional witness with respect to the Dental Association. So we would like to add the witness of Angela Purcell, the Dental Association Executive Director or Designate. So I would like to move the additional witness be added to the NDP's motion for topic of children's oral health.
So there is an amendment to add an additional witness to the oral health. All those in favor? Aye. Opposed? And the original motion is question. Ms. Adams.
I'm just wanting to ask if there's a reason why we're identifying just children's oral health and not everybody's oral health, and whether it would be an opportunity to discuss seniors' oral health, or whether there was a specific reason why we only wanted to target children.
Ms. Martin.
because we feel that that would be a different topic, and we just had a very fulsome discussion and presentation from the Dental Hygienists Association of Nova Scotia about children's oral health.
Okay. That answer? Okay. So the topic for the NDP will be children's oral health with the added witnesses. Okay. All those in favor? Opposed? Motion is carried. That, thank you for making up the witness list for the next while. Our next meeting will also take place October 8th. Note the time, we're saying 9 to 11 because we are thinking that the legislature will be sitting at that time. So we will not meet at the usual 1 to 3 p.m. It also does not fall on the long weekend. There's a little worry there. So we will meet again on October the 8th from 9 to 11 o'clock. The topic to be determined, and I'm sure the clerk will, as soon as she knows what the schedule will be, she will let us all know. So business is concluded, and I adjourn this meeting. Thank you.